Good morning, everyone, and thank you so much for joining us on this webinar. My name is Sarah Wendland, and I'm a trainee educational psychologist from UCL on placement at Southend-on-Sea.
Hi everyone, I'm Lauren Baggley. I'm also a trainee educational psychologist working here with the Southend team.
Hello, I'm Dr. Tina Axup, senior educational psychologist at Southend. Today we're going to present the first webinar. It's going to be a series of 5, and it's to support the foster carers and adoptive parents in the community. But we hope that even if you're not in this group, that this will help the children and young people you care about and look after.
Thank you, Tina. I'm just going to share my screen and hopefully you can all see this. And as Tina said, this is the first session of a series of them around social communication difficulties and children who have difficulties with regulation. So the aims for this session are to build an understanding of children and young people with social communication difficulties, including those with a diagnosis of autism, and the same for children who have difficulties with regulation, including those with a diagnosis of ADHD or ADD. And we're going to consider the different constructs that these are created within, so something called the medical model and the ecosystemic model. And as Tina said earlier, at the end of the presentation, we will have time to talk and think about this together, because they are topics which invoke lots of discussion and can be a little bit controversial, so it's really important that we have those opportunities to discuss that together. So hopefully that makes sense for everyone. And start off by thinking about the different models of understanding and how we create understanding of these two diagnoses of ASD and ADHD. So there's different models and they all have their own place in the world. They've all got their own uniqueness, and it depends on which professional you're working with which model you might be using. So if we think about the medical model, which is the one on the left hand side, this is the one that you might typically experience when you go to the GP or if you go to anyone around a health need, and they have a very specific set of criteria which they're working towards to help them understand if you meet the criteria for a diagnosis or not. So when you go in to meet with the professional, typically a doctor, a GP, something like that, they will be asking you things about your symptoms, what is happening for you, and really focusing on the difficulties that you are experiencing as a person or the child is experienced at that time. And they will look this up and see whether that all fits their criteria for a diagnosis. And if they give you a diagnosis, then they'll be looking at thinking about treatment and supporting that with things such as like medication, or referring you to another specialist, or looking at if there's anything dietary, all of those aspects of it within that strict construct of their symptoms and treatment plan. And that's the experience of the medical model, and it has its place because it's important that we are able to look at that, look at the needs, look at the things, and provide that specific diagnosis. On the other side, if you were to work with an educational psychologist such as us, we typically use the ecosystemic model, which is different from the medical model because we look at all the different environments that a young person or a child is experiencing. So if we look right at the centre of that diagram, we've got the young person, and then you can see around them, you've got things like school, home, family, peers, the neighbourhood, any outside activities they might be doing. And we think about all these different environments and how they interact and affect the young person and impact on the young person. And we very much look at thinking about identification. So we're not specifically diagnosing, we're identifying underlying needs and thinking about their characteristics, their strengths, their difficulties, and how these interact with one another to create a good understanding and picture of that young person. We will also think about them as a person from their whole life. So we'll think about the development of that child or of that young person, so what they've got to at the moment. So we might be asking about sort of this history of the young person, and in particular thinking about the social relationships. So if we think about children who are experienced in care, we might ask about, you know, what was their life like right at the beginning of their childhood, those relationships, what was that like, how did that progress, what's moved on. So really building up a full picture of that young person and what their needs are, and then looking at the environments around them and how they might be impacting on that child at that time, and is there an environment where they really do really well in, and can we adapt other environments to fit and support that. So it's more about the systems around the child and not just necessarily the individual child, which the medical model has more of a focus on, of that individual child. I don't know if there's anything else you want to add in there, Tina.
Yeah, I think when you get to the, as you can see, that there are two different sets of language about this, and this is something we come across a lot in our work that people are quite confused about. So this is why we decided to explain this. But when it comes to the actual strategies, we would say strategies rather than treatment, because we wouldn't be treating an individual child. It's not a biological model mapped onto these difficulties as a medical model is in some ways. We would be thinking about how can we shift the environment and educate and help parents and teachers and all the people working with that child to generate change, rather than giving, for instance, a child some medication. So we're looking out and around the child. We may be looking at cognitive functioning and different things like that, but we start at the edges and work in, if you look at that model. So first of all, we might be thinking about, are they sitting in the right place in the class to be able to focus? Are they getting the right support in class? We would also obviously we would look at the medical things like vision, hearing, etc. obviously at the beginning, but we wouldn't necessarily go for the problem residing in the child. We would be looking at how we can shift things around support systems. So that's where the identification of the issue is really important. Rather than looking at a checklist, we would be asking the people that are concerned, what are the actual things that are preventing this child from learning or preventing this child from developing relationships? And then be thinking about strategies to support that, and also be thinking about the meanings of behaviours, which is of course really important for the children that you're looking after, because they've often had a very traumatic background, and we need to know the story and what that behaviour is communicating. So I hope that's kind of given you a picture of the two models and how sometimes they use together, but our model does capture more children in a way, because we do have children that don't meet all the criteria for a diagnosis but still have difficulties. We have children that are sitting on waiting lists, and we're able to get there before they actually get an assessment through the medical model. So ours is a much more broader remit in a way than the medical one. So there are pros and cons, and there are a lot of myths around diagnosis and needing a diagnosis for certain things, which we're happy to obviously have a conversation with you at the end. Okay.
So thinking of ASD and ADHD, they both fall into the bracket of neurodiversity. And if you look at the left-hand picture, you can see there's lots of different characteristics, diagnoses, aspects of a person that fall into the neurodiversity category. And actually, lots of them overlap, and you can see elements in from lots of the different areas. So it's not as clear cut as you get a diagnosis and this is it. This is the end. So that within that neurodiversity category or collection of differences, that you can see aspects in lots of different ones, and it's really about trying to understand them and see how they're impacting on the young person and the child, and how we can support that. And if we're thinking specifically about ASD and ADHD, so we've got roughly 1% of the population has a diagnosis of ASD, and for children with ADHD we have between 3 and 5%, but this decreases when you get into the adult population down to about 1 to 2%, because some have their diagnosis removed, and they might still be displaying symptoms, but yet they're in environments that are actually really supportive of them, and it's not as noticeable. So they're not in a classroom, they're now actually in work, which really supports them as a person, and they feel they don't need that diagnosis anymore. And with both ASD and ADHD, they are overrepresented within the male community population. So ASD is a roughly 3-to-1 ratio of males to females, and ADHD has a rough ratio of 4-to-1. And there's lots of different reasons for that. And for ASD, one of them is around the idea that we don't actually have a full understanding of ASD within the female population. And it seems that they are typically better at possibly masking their difficulties when they're younger, and actually their needs become more present and more prevalent when they hit their teenage years, and maybe they aren't able to cope or to mask their needs as much as they become older, and that is not quite yet reflected within maybe the criteria which are used to diagnose ASD. And I know Lauren has something about ADHD as well.
Yeah, thanks, Sarah. There's a similar thinking within ADHD as well. Girls are underrepresented in referrals for ADHD, and one of the possible reasons that's been put forward for that is that perhaps similar to Sarah's description of children with ASD, it may be that girls are better at masking and sort of managing those symptoms, and they're not as prominent or as noticeable in the classroom. It's also thought that girls perhaps might present with more inattention than hyperactivity, and it's quite interesting to think about that presenting in a classroom and what sort of behaviours are challenging and kind of will be noticed and will be quite prominent. Tends to be the hyperactivity rather than the inattention. So that's one possible explanation of why that might be. It's just useful to keep that in mind.
Thank you, Lauren. So thinking about autism and what is autism, if we think about the medical model, they have got these criteria. So the DSM-5 and the ICD-11 are the medical manuals which all medical professionals use to conclude diagnoses. So for autism, they have to have difficulties within interaction and social communication, and restricted interests or repetitive behaviours, including sensory needs. And these difficulties must be present since childhood, and they must limit and impair everyday functioning, really. And it is recognised that these symptoms may not fully manifest until later years when the social demands exceeds their capacity. So this is what I was talking about earlier about girls with their masking. It's possible that actually they are within their sort of social demand, but in later years this will be exceeded, and therefore we might start to see their difficulties more. And with the restricted interests and repetitive behaviours, we within the EP world might sort of talk about their restricted interests as actually, are these actually specialist interests? Are they really utilising their skills? And it's not necessarily a restriction. Their interests can be really become their passion, and actually they can go on and have really great careers in aspects which we might typically not want to do, but for them it's a real strength, and it's really utilised. So we might challenge that idea of restricted interest and think about it as a specialist interest and an area that which they can succeed in. So that's something that might be slightly different. And we're going to now think about the interaction of social communication in more of a way of what we might see. So on the side you can see lots of different things, and we'll just pick out a few. So in social interaction, we might find that children and young people really struggle to regulate themselves in conversation and understand the typical way a conversation will work. So the serve and return aspect. So I'll say something and they'll respond something. So I've worked with quite a few young people who you can see that they don't quite understand that, and I might be talking about something and haven't quite finished what I'm going to say, but they've not understood that, and they've either turned around and walked off, or they've started talking about something completely different that's completely unrelated. And that's quite a typical thing we might experience when working with children who have got social communication difficulties or a diagnosis of ASD. And I think Lauren and Tina have examples as well of the other two.
Yeah, I was thinking about the unwritten social rules and that insensitivity to other children, others' feelings, because there's a term called theory of mind where people with autism are not great at intuiting what effect their behaviours and words have on other people, so they're not necessarily able to think about that before they say things. So a classic one I've heard lots of people report is a child in a supermarket seeing a large person and saying very loudly, that person's eaten too many cakes. And of course that's very hurtful to hear and very embarrassing, but they wouldn't have necessarily thought that before they've said it. So they often think things and say it spontaneously without that social filter. I think you've got one, Lauren.
Yeah, just thinking about those special interests, which Sarah really helpfully kind of framed there, and how we might not necessarily think of that as a rigid or a negative thing, and just thinking about maybe some of those restrictive behaviours. When I was thinking about planning an organisation, something that particularly came to mind was how common it is for children with ASD to be really concerned about their routine and really concerned about what's going to be happening, and just finding that really difficult to manage, and that's where we might start seeing some of those anxious repetitive behaviours such as the pacing or the little routines in an attempt to kind of feel safe and feel reassured. And I was just thinking about one example that's actually come up many times of needing a visual timetable that actually goes between home and school to keep that continuity and keep that kind of ability to forward plan and be able to look and see what's coming. Seems to be something that comes up again and again, and to have that as a visual to be able to reassure, that seems to be really prominent. So that's just one example of where we might see that.
Thank you. And I think the real thing to pick up on with the interaction and social communication skills is that actually we need to teach these skills to these young people. They don't necessarily pick them up through watching and observing others, as typically developing children might. So these skills need to sometimes be explicitly taught and to be shown to the young people so they can understand how to interact and to communicate with others. And then thinking about the rigidity and repetitive behaviours, as Lauren's already mentioned, you know, these can be within their routines, their behaviours, in the way that they play and how they feel within their environments. And it's really thinking about sort of where these routines might possibly sometimes overtake their life because they have to do them. It's an aspect which makes them feel comfortable and safe. So I worked with a wonderful family the young person had to have the same walk to school, and mum one day added in a small stop off because they were really early, and then from that point on that part had to become part of their routine, and every day they had to then make the same stop because it'd been added in and it was unexpected and they found that difficult, but then it became part of that routine. And it's little things like that where the routines become almost what they have to do to help them feel comfortable and safe. And this is where the sensory behaviours also may feature really prominently, and this can sometimes be called stimming within ASD. And this is where you will see repetitive behaviours which are providing sensory feedback. So this could include walking up and down, it might include spinning, it might include rubbing something. So all things that will really engage their different sensory aspects, which we will look at in later presentations. Because it actually provides them sensory feedbacks and help them feel safe and in control and calmer within that environment. So that's a few of the things with rigidity and repetitive behaviours.
Yeah, can I just come in on that? Sorry, Sarah. I think it's really important, first of all, to really think about commonly people see repetitive behaviours and think autism, but it's quite common for children who have had lots of trauma to need to be in control of their circumstance because they've been in unsafe environments. So they may create ritualistic behaviours and very strict routines to feel that control. So it may come from another place other than autism. So it's really important to look at the whole child in the round in thinking about autism, rather than jumping on one particular thing that may be about control for another reason, which is why the whole story is very important. And the other thought I had was around play. It's play often signals this at a very early stage. And this kind of not being able to engage in imaginative play, not being able to pretend something is another thing, like a banana is a telephone. And they're all precursors in a way to that social aspect of life, which we spoke about with the other slide. So if the play doesn't come in a natural way, as Sarah said, that these children will need to be taught how to play. But that is the bedrock of social interaction. So that's a really important thing if you're working with children, say under 5, well, over 5 as well, but where play starts, I think that's very important. Thanks.
And thinking about autism, you often hear people talk about the autistic spectrum, and this can range from sort of low or lower level needs through to high level needs, and can often be seen in parallel with with learning needs and difficulties developmentally. So if we were looking at the low end, you might describe this as sort of classic autism, where children have very limited verbal language, and they also have limited skills in multiple areas, and that's what you would see, that they would have difficulties across the board. Whereas if we go up to the higher end, you might have children who actually display really excellent skills within their language ability, but they might struggle with other areas of their within their needs. And Rebecca Burgess, who has created these pictures that you're seeing at the moment, has created a really nice comic strip to help people understand this. And she's described it as more of a circle, and that it's more of a spattergun approach, and you can have areas where you've got real strength and areas of where you've got real need. And it's important that we think about these different areas and not just say, oh, you've got mild autism, because that doesn't capture all the different areas where strengths and needs.
Yeah, can I just add, actually, I think wherever you are on the spectrum, whether you have a learning difficulty and your skills are very limited, to where you are very high functioning and probably perhaps in a grammar school, none of them are mild in terms of the difficulties, because they throw up their own issues, and both groups of children and families have very specific difficulties which can lead to mental health problems and lots of things like that if they're not managed properly. So I just wanted to say, you may have heard of Asperger's syndrome. That's actually not diagnosed anymore, but it has come under the umbrella of autistic spectrum disorder. So in a way, as soon as you talk about ASD, instead of having those demarcations of Asperger's syndrome, high functioning autism, the spectrum's got bigger under the general label of ASD. So we're maybe talking about children, say, with very limited skills, up to children who are very, very high functioning. But some of those high functioning children are able to mask their real difficulties with social communication with their language. So they may not have the understanding, particularly the social understanding, although they may be very articulate, and particularly within their interest area.
Thank you, Tina. And then just very briefly, thinking about causes, there is no single cause for ASD. There's no biological marker that you can test for, but there are things that we are aware of, so that things like genetic links, maybe some neurological differences, but the most likely thing is there's probably lots of different factors which have impacted, and therefore autism has come about. But we have no evidence of exactly a single cause, and if there was a single cause, we would have found it by now, because there's been lots of research into this. So it really is thinking about there's lots of different areas that impact on it, and we need to just understand what is the current situation and how can we support moving forward, rather than searching for a cause, because even with knowing what the cause is, that we might not necessarily be able to target that. It really is about understanding the child's needs and developing support around that. Moving on to Lauren and ADHD now.
Thank you. Yeah, so we're just going to have a think about ADHD in a very similar kind of presentation that Sarah has just done for ASD. So we're going to have a little think about the diagnostic criteria and have a look at the medical model, what the medical professionals would be looking at in terms of diagnosis. Then we're also going to have a think about how we might work and how we might see different presentations of ADHD or children that have regulation difficulties. I'm going to think about that in terms of the environment and the different needs that might be presented to us, perhaps maybe if we had a consultation with yourselves or school staff. We're going to have a look at how those two things sit alongside each other. Okay, so just at the top here, we just have the medicals. This definition is from the NHS. So as a general kind of definition, attention deficit hyperactivity disorder, or ADHD, is a behavioural disorder, and it includes symptoms such as inattentiveness, hyperactivity and impulsiveness. And it's just important to note as well that of course there is ADD, which is just missing that hyperactivity element as well. So the symptoms for this tend to be noticed at an early age, but it becomes more noticeable commonly when circumstances change for the child. So a really big one is when they start school, and we think that perhaps maybe this is because they then go into a different environment where they're being required to do things where these difficulties are going to show. So they're being required to sit and focus for certain periods of time, and so that might be when we start to see those difficulties with staying still, that inattentiveness, and so on. So it's just that the presentation perhaps becomes more dominant when children might start school or have quite a big change happen in their routine. So this is probably why most children are diagnosed when they're between 6 and 12 years old, so that school age sort of period. And then it's just important to note, Sarah touched on it earlier, symptoms usually improve with age into adulthood, not always. But again, as Sarah mentioned, we wonder if perhaps that may be because adults actually will draw themselves to environments where they can utilise their strengths, and will perhaps find environments and careers and whatever they might do where they're not being required to do the things that they find as challenging. They have a bit more freedom over doing that and making those choices. But it is just important to remember that people with ADHD may have additional difficulties, and this of course can continue into adulthood, so it's important to note that. Most commonly it seems to be sleep difficulties, and also sometimes anxiety disorders, which kind of go alongside this presentation. Okay, so just really quickly, just having a look at here, this is the DSM-5 diagnostic criteria that we spoke about within the medical model. So the symptoms fall into the categories of inattention on the left there, and hyperactivity or impulsivity. So these symptoms, if you're 16 or under, we would be looking for 6 or more of these symptoms across these areas, and if you're 17 or over, you'd be looking for around 5+. What's really important to think about with this is that paediatricians or medical professionals would be looking at this criteria across the home and the school environment. So they'd be looking for the presentation in both of these places, and also they would be looking for these symptoms in a developmentally inappropriate way. So this is probably why it becomes more prominent when children go to school. If we have a look at the kind of the different things listed here, we would expect quite a lot of these in very young children, and that would be perfectly normal for us to see and wouldn't necessarily be indicative of anything. However, that's the important focus when children go into school and they're among their peer group of children the same age, and some of these behaviours seem developmentally inappropriate. That's when professionals will be looking at this and thinking about a diagnosis.
And can I just point out that because the group of children you're looking after are likely to be hypervigilant because they may have lived in unsafe homes, or have been born drug addicted, or have had early pre-birth and birth difficult experiences, these go with the territory in a way. So it's important to kind of look in the context of the behaviours in the context of their story. and they may be developmentally lower in these behaviours. So it is important to look at their chronological age versus their emotional age, and say look at as a whole person rather than kind of pick out individual characteristics. But of course, if we pick out individual issues, we can often look for strategies to support those things.
Yes, absolutely. Thank you, Tina. So yeah, this is where we're kind of moving into thinking about, as educational psychologists, kind of the work that we might do and things that we might be looking at. So as I mentioned before, we might have a consultation with you, we might speak to school staff, we might observe the child or the young person in their school environment, and take lots of different things into consideration. And this is where it's thinking about how we would look at the presentation of the strengths and the needs in comparison, how that sits alongside that medical model of diagnosis and looking at the symptoms. This is where it's kind of hopefully going to become a bit clearer why we're talking about children with a diagnosis of ADHD, but also children that may not have a diagnosis, but they may still have difficulties regulating. And hopefully on the next slide, that might become a little bit clearer. So I just put a few things that kind of commonly come up. I thought it just might be helpful to have a look at kind of the common things rather than looking at a list of symptoms. These might be things that we might see, and we can see things like disorganisation coming up in here, difficulties with remembering things and getting things organised. We can see this impulsivity, so like she has no fear, for example, that risk taking, something that comes up quite often, and we can think about kind of the impulsivity within that. But there's also things within this that very much map onto difficulties regulating as well. So that, you know, wait your turn, that needing to give an answer because you just have to say it just then. And there's lots of things within this that are also sensory seeking behaviours. And so we can link that to regulation in there as well. So, for example, we have things like stop fidgeting, which we can very easily map alongside those list of symptoms, but we can also think about in terms of a child that may have difficulty regulating and may be on the move because that's comfortable for them, that's something they feel they need to do, and they get sensory feedback from that, and it's you know, it's an experience that they enjoy, and so they seek that. So these are just kind of the different presentations and all the different things. You know, obviously there will be far more examples. These are just a few kind of common ones, but these are the sorts of things that we might look at and we might think, how can we adapt the environment? How can we support the child with these particular issues in the context that they're in? So that's how we might look at it. Okay, I'll go into this in a bit more detail because we've got another session looking at this, but I just wanted to kind of introduce and touch on, again, very similar to what Sarah said with the ASD. It's very much a grey area when we think about causes for ADHD or self-regulation difficulties. It's certainly not a direct cause and effect in the same way that Sarah said. There's been lots of research, and if it was a direct cause and effect, we would have that now. So there's some different areas that are thought about when thinking about the causes of ADHD. One of those is genetics, and that's because ADHD is found to run in families. So that's interesting to think about. A child that has one parent or a sibling with ADHD is slightly more likely to receive a diagnosis of ADHD themselves or to encounter those same challenges. But there is certainly not a single gene that, for example, makes ADHD heritable, so you wouldn't be able to kind of pinpoint that to an individual gene. And it's also really important, as you're going to find with all of these things, there's so many interacting factors. When we think of genetics alone, we need to think about the fact that a family will share an environment, and then there's going to be individual features which I'll go on to within that, which may be a possible cause or a possible explanation of some of the things that we might be seeing. There's also neuropsychological ideas and theories. Again, this is definitely not a direct cause and effect. there's research around different levels of chemical, particularly the stress chemical cortisol in the brain, and that takes me back to what Tina was saying earlier about you know, children that you will be working with and that you will have experience with, that have experienced perhaps a very stressful or chaotic early life, and then we know that that influences kind of levels of stress chemical in the brain and influences healthy brain development as well. So you're starting to see all those ways that they influence each other. There's mixed research on brain size, for example, with some studies finding that brain size is slightly larger in children and young people with ADHD, and then others find slightly smaller. So it's very kind of inconclusive and ongoing research into that, where we can't draw a direct cause and effect. And then again, thinking about environment, which again, as you're starting to see, everything is linking together. Environment, obviously, we know that for healthy brain development and to feel safe and secure, and for that healthy emotional development, we need a safe and secure environment where our needs are met. And so when we're thinking about some children whose early experiences perhaps are not having consistent care or not having an environment that is kind of settled and stress-free, we know that that can produce some of those presentations of hypervigilance that Tina mentioned, and we can see very much how this would link onto some of that inattentiveness, some of that presentation that actually may have developed because it's kept those children safe and it's been a good strategy, and that might be why that's come about. So that's one example of kind of an individual factor of environment and how that can link in. So these are all linking together. And then finally, just wanted to briefly mention diet, because that's been something that through time has kind of come up and there's been conflicting views about that. At the moment, the research suggests that diet is not a significant factor in causes or explanations of ADHD. But of course, as we've said with everything else, it's kind of that anecdotal evidence, and it's listening to people's experiences. Some people really find that keeping a diary of certain food triggers or introducing certain regulating foods is really helpful for children and young people's behaviour and just helping them manage some of their difficulties. So that's really interesting to think about, and it's kind of that anecdotal evidence that we're interested in. It may not be so much that the research is saying about diet, but if you know, for example, yourselves are finding that there are certain things within diet that are helpful, that's something we want to know about, because that can be supportive. And just, yeah, as a bit of a finishing note on this, I think it's shown all the way through, because I'm struggling to describe them as individual things. These are all linked together, and it's all individual factors within these main things that could be different for individual children. And so for us, it's really looking at those individual factors, how they interact, what the presentation is, and most importantly, what can be adapted to support with that.
Lauren. So thinking about diagnosis of either ASD or ADHD, they have really similar pathways if you do go down the sort of the diagnostic route, and that is typically, you know, you go to the GP, you'll get a referral to a paediatrician, they will undertake an assessment which will often include multiple considerations. I know for ASD they have to consider lots of different aspects, and that's within the guidelines. And then from that, you might receive a diagnosis or you might not. But that's the typical route following through for both ASD and ADHD. And after the diagnosis, there might be support options which will be provided with through the different services that are out there.
Yeah, and can I just say that NICE guidelines have suggested multi-agency teams, which probably reflects what we've been saying in the presentation, that there's so many different aspects. It's really important that a thorough assessment includes those different professionals. So it may include speech and language therapists, a psychologist, perhaps a paediatrician, occupational therapist to look at sensory issues. So it's really important that the children are looked at holistically, and there's a move to that multi-agency way of working as the gold standard rather than just a single diagnostician.
Thank you, Tina. That brings us to the end of our presentation, so thank you ever so much for everyone attending and listening to us, and hopefully we'll see you in the next webinars. Thank you. Bye.